Bismillah wa salatu wassalam ala Rasulillah. Welcome all medical students for our second lecture in general surgery, which is acute abdomen. And as we know, acute abdomen is one of the most common cases which present to ER. Our specific learning objectives: define acute abdomen, describe anatomy of the visceral and parietal peritoneum, explain the pathophysiology of pain and relate the pain site to the embryological origin of the organs, describe the clinical features of acute abdomen, demonstrate understanding of the investigations and common management of patients with acute abdominal pain. So we'll go through the first specific learning objective, which is define acute abdomen. An acute abdomen actually denotes any sudden, spontaneous, non-traumatic. It can be severe, it can be moderate, and the severity is something subjective. I cannot measure it. Abdominal pain, typically less than 72 hours in duration. Actually, regarding the duration is not that clear. It is 72 hours. Maybe some pain will be for more than 72 hours, and still we can say it is acute abdomen. So suddenly started, so we can say it is acute abdomen, but it increased gradually, and it start as mild pain, then became severe. So still the starting of the pain is still sudden, and still I can say this is acute abdomen, but at the same time it is gradual in onset, that it reach maybe 4 days even. So the duration is not precise that it is 72 hours. You can find it in some books more than 72 hours. It can be even for 5 or 7 days. But we can say up to 72 hours, it's still acceptable thing. Here we have to describe the anatomy of the visceral and the parietal peritoneum to understand how does the pain presented on the patient, and then we can go further to explain the pathophysiology of pain in understandable way. So there are some facts we have to understand them. The first fact: organs itself aren't innervated by sensory nerve. So we don't have sensory nerve in the liver, we don't have sensory nerve in the intestine or other visceral organs, whether it is solid organ or hollow viscous organ. The peritoneum actually is innervated. We have two types of peritoneum actually, as we know that we have visceral and parietal peritoneum, and they have two different types of innervations: autonomic, which innervate the visceral, and somatic, which innervate the parietal peritoneum. Just to refresh our memory regarding the formation of the peritoneum, we can imagine that the peritoneal cavity like a balloon, and organs go inside this balloon from outside, and the part which is covering the organ and directly in contact with the organ, we can call it visceral, or which we call it also the inner layer of the balloon in relation to the organ, and the outside layer we call it the parietal. So here the visceral peritoneum actually is innervated by autonomic nervous system, and the parietal peritoneum innervated by somatic nervous system, in addition to the some nerves and receptors in the wall of the intestine or in the wall of the stomach can be afferent nerves for pain, but it is not very clear. And actually, it is not important to go in deep details of such pathophysiology. Just we can understand the general idea about it to understand how the patient will present to you. So here, as we see now, that sometimes the parietal peritoneum can be part inside the abdomen, and this is which we call it the mesentery. So the mesentery, some part of mesentery is actually, it is innervated by somatic nerves. So at the same time, we can see some organs are far away from the parietal peritoneum, that sometimes, even if they have severe inflammatory process, the clinical features will not appear on the patient directly. How can this affect our differential diagnosis? Let's see here what is the characteristic of pain which is coming from the parietal peritoneum. The parietal peritoneum, as we said, it is innervated by the somatic, and the innervation is unilateral. And this unilateral innervation, will give us very important thing, which that the patient can localize the pain. And also the character of pain will be different. So the pain will be sharp and associate with abdominal signs, like because it is somatic. So because also the nerves are sensitive to touch, irritation by chemical, by cutting, and other mechanical stimulation. And if I have signs that reflect the parietal peritoneal irritation, it frequently, rarely signify need of surgical intervention. Let us see here with what will happen if the pain comes from the visceral peritoneum or from the visceral nerve, or the nerve which is giving pain from the visceral organs. The innervation is autonomic and it is bilateral. So the pain cannot be localized. This is the most important thing here. Here in unilateral innervation, the pain can be localized, but in the autonomic innervation, it is bilateral and cannot be localized. And the character of pain is usually vague and come in the midline and associated with autonomic symptoms like nausea, sweating, and nerves are sensitive to stretching, inflammation, and ischemia. So if I cut this nerve by a knife, I cannot stimulate them. If I irritate them by touching, I cannot stimulate them. So such pain rarely signify need of surgical intervention. So these physiological facts are very important for us to start talking about the pathophysiology of the abdominal pain. So these pathophysiological facts are very important, and it will help us to diagnose a patient with acute abdomen. So we just talk about localization of the pain. We have to know the geography of the abdomen. So the surface anatomy of the abdomen should be very clear in our mind. And we have actually two types, and both of them are right, but one of them is more precise than other. So for example, in B, you can see that this is more precise because we have more divisions. So I can say right upper quadrant, which can indicate that right hypochondrial and right lumbar region. Let us take them in details a bit, just to know how did we divide the abdomen in such divisions or in such regions. So in the quadrant divisions, we have 4 quadrants, and it is the product of 2 lines, which is vertical and transverse. The vertical line started from the xiphoid process down to the symphysis pubis, and the other horizontal line will cross it at the level of the umbilicus. So now we have right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And the other picture, which is B, we can see here we have 9 regions. And actually, this is the end result of 4 lines. 2 of them vertical lines at the midclavicular line going from up down, and the other horizontal line, the first one, actually it is at the level of the lower part of the rib cage, and it is at level of L3. Also cross the third part of the duodenum. The second line, it will join the tuberosity of the iliac crests, and this is at the level of L5, or it is in the uniting of the both common iliac vein. So this is just a landmark. We can just memorize it by this way. So this is will help us to divide the abdomen into 9 regions: right hypochondrial, epigastric, left hypochondrial, right lumbar region, umbilical region, left lumbar region, right iliac region, hypogastric region, and left iliac region. Sometimes you will find it like right iliac fossa or left iliac fossa rather than region, and both are right. Here is a very important thing that we can look at it, that the autonomic nervous system actually it innervate the viscera, and it is sympathetic and parasympathetic. The sympathetic, which innervate the GIT or the intra-abdominal organs, it starts from T5, but generally the sympathetic nervous system comes from the spinal cord from T1 to L2. So we can memorize it by this way, that it started by 1 and end by 2, started by T1 and end by L2. The vagus nerve innervate the gastrointestinal tract or the intra-abdominal organs, and the lower part of the intra-abdominal organs like the urinary bladder and the uterus, it is innervated by the sacrum, innervated by the sacral plexus. So the parasympathetic in the whole body comes from cranial and from sacral plexus, and the sympathetic comes from T1 to L2. Now this is general innervation, but which nerve of these nerves are responsible about afferent as a visceral pain? And this will be reflected on the patient's symptoms. So let us take an example. If I have a patient that has pain in organ X, and this organ X innervated by sympathetic nervous system as afferent nerve, the efferent will give us the symptoms of the sympathetic nervous system. So the patient will have nausea, sweating, vomiting, pyloric spasm, for example. The other organ, which is Y organ, innervated by parasympathetic. The efferent of this parasympathetic will be the parasympathetic symptoms. And these are very important to understand the neurological basis of the pathophysiology of the pain. Just to refresh our minds regarding the origin of the sympathetic and parasympathetic, we can say that the parasympathetic comes from September 1973. The September is for sacral, and 1973 here for 10th vagus, glossopharyngeal 9th, facial nerve, and oculomotor nerve. These cranial nerves, they give us the parasympathetic in the body, and also we can add sacral plexus, which give us the pelvic splanchnic nerves, which innervate the 6 organs and the urinary bladder. The sympathetic, as we said, it comes from T1 to L2. We have just given that example of the organs X and Y. And here will be very clear. If I have any problem in these organs, the patient may present to you with the symptoms of the sympathetic nervous system, like sweating, nausea, vomiting, and other symptoms of the sympathetic overstimulation, because these organs' afferent nerves go through sympathetic nervous system. And it will go, and the efferent will come back to the organs and will affect on it by a reflex. And the patient will have sympathetic nervous system stimulation. In the visceral pain, actually, according to the organ's origin in the embryological life, you can specify the region where it can be presented on the patient. So, if the pain comes from the foregut, because it is innervated by the celiac plexus, the pain will be presented on the epigastric region. So any pain from pharynx down to the third part of the duodenum, the patient will have epigastric pain, and it will be central, which is visceral pain. The midgut pain. The midgut will start from fourth duodenum to the proximal 2/3 of the transverse colon. Because it is supplied by the superior mesenteric plexus, the pain will present as periumbilical as visceral pain. The hindgut, the rest of the colon and the rectum, it is supplied by the inferior mesenteric plexus, and the pain will present suprapubic. In this picture, we are seeing very important thing, which is referred pain and the pathophysiology of referred pain. Actually, any pain can start in the midline, can also stimulate the somatic part, which is innervated by the same segment. So the pain may be referred also to that area, or we can say radiated to that area. So, for example, if I have a patient with gallbladder problem, the pain may be referred to the right shoulder, and at the same time to the tip of the scapula, because these area have the same root value in the spinal cord. The pain also can be shifted, so the pain can start as visceral, and then once the inflammation reaches the parietal peritoneum, it can be shifted to the right iliac fossa, like patients who is having appendicitis. Rectal pain can be referred to the back of the patient. So these have a lot of theoretical background, and there are several theories behind those things, and it is very interesting to go through them. Like, for example, one of the theories say convergence projection. So here we have the local pain, which comes, for example, from the gallbladder as a first order neuron. So we can go back a little to the basic knowledge of the physiology. We have actually three order neurons. The first one comes from the visceral to the spinal cord, and the second one will go to the thalamus, and from thalamus it will go to the cortex. So we have three orders neuron. We have first order, and we have second order, and then the third order. So suppose that we have a gallbladder vein here and taken by this nerve to the second order neuron. The second order neuron receive also from another region some nerve. So once this reaches to the cortex or to the thalamus, the patient will feel the pain in both areas, like in the epigastric or in the right hypochondrial area from the gallbladder and on the shoulder. So the brain cannot differentiate from where it is coming. So the patient will have both pain. This is, we call it convergence projection. In the convergence facilitation, that they thought the other or the localized nerve from the gallbladder, it gives some small dendrites which goes to the second neuron, other nerve, second order neuron, other nerve, which will be also represented in the cortex or in the brain, like if it is coming from this area which is the shoulder of the patient, and the brain cannot differentiate between them, whether it comes from the shoulder or it is coming from the gallbladder. So the patient will have both pain together in the right hypochondrial area and in the shoulder. The thalamic convergence, actually this will happen on the third order neuron, where both of the second order neurons will innervate one nerve, which will go to the central nervous system, and the brain cannot differentiate whether it comes from the gallbladder or comes from the shoulder. Actually, in the books, you will be confused a bit, because sometimes you will read it referred, sometimes you read it shifted, sometimes you read it radiated pain. We cannot say that they are really means the same. For example, if I take here referred pain, it means that the pain in the original area is there, and I have another pain in somewhere else, like gallbladder as an example, and the right shoulder. So I have here pain, and I have there pain also. This is, I call it referred pain. The second type of pain is shifted pain, and this is actually different. It is like I have here pain, and then this pain is stopped and shifted to the other area. Like pain in the appendix started as visceral pain in the periumbilical area, and then this pain will subside or decrease, and I will have only one type of pain, which will be in the parietal peritoneal irritation. So the first pain in the periumbilical area was visceral, and then it shifted to the right iliac fossa or right iliac region as parietal pain, and the character will be different. So this is which we call it shifted pain. Let us see here the radiated pain, and let's use another color, so this will help us to understand more. So here the radiated pain, you have the source of the pain still there, and there is a continuous pain going along with the area of the pain. So like source of light and the rays of the light. So you will have pain. For example, myocardial infarction will present with the retrosternal pain, and also pain which radiated to the jaws and to the left arm. So here just more explanation about these different categories of clinically interpreted types of pain. So you can maybe avoid any confusion if you understand this nicely. Now we want to describe the clinical features of the acute abdomen. Any patient, actually, let us take it very simple, that we have a patient now with acute abdomen. First, we have to take from this patient history. And actually, this will give us the clinical features, which will take us to the diagnosis. And then from diagnosis, we can go to the precise treatment. So in the history, you have to know the location of the pain. As we just discussed before, the area of the pain is very important for us to know. And then we will have more examples to explain to us what is going on. The mode of onset. This is also very important. The sudden pain, usually it can be differential diagnosis of three things. So either it comes from rupture of hollow viscus, this is the sudden pain, obstruction of hollow viscus, or embolic occlusion of artery, which end up with ischemia. So ischemic pain, rupture pain, or obstructed pain can start suddenly. So how can I know that it started suddenly? Everybody maybe will come to you and will tell you, doctor, I have a sudden pain. How can we differentiate between sudden pain and pain which didn't start suddenly? The patient with sudden pain will tell you the exact time when did the pain started. So he will tell you the pain woke me up from sleeping at 9 o'clock. Or the pain came to me while I am eating. So he will precisely tell you when did the pain started. But the patient who is having gradual onset pain will tell you, doctor, yes, the pain started with me like during afternoon times, and then after that increased, and so he cannot precisely tell you the time of the onset of this pain. The pain character, vague character like pressure, like something like that, it is really indicate visceral pain. And the other characters like sharp, like cutting, or like a knife goes in this area, This is most likely indicate parietal peritoneal irritation. The other associated symptoms, we know that if the organs is sympathetically innervated as afferent nerve, maybe the patient will present to you with other symptoms of sympathetic nervous system. For example, why the patient with appendicitis who's having appendicitis, he will present to you with vomiting once or twice, because these people actually they will have sudden pyloric spasm because of overstimulation of the sympathetic nervous system, and then this pyloric spasm will cause vomiting once or twice, and then things will subside because the nerve will adapt with this pain and the efferent will not give the same reflex. Past medical history is very important. Patient with diabetes will not respond to the pain like patient without diabetes. For example, surgical history, like a patient who had, for example, laparotomy before, maybe they will present to you with adhesive intestinal obstruction, and the patient will have severe abdominal distension and other. So this will guide you in your diagnosis. Gynecological history is very important thing, and you have to take detailed gynecological history regarding the last normal menstrual period, and which will indicate for you that maybe this patient is pregnant and she present with acute abdomen because she has a ruptured ovarian cyst, or maybe very similar than that, it is mid-cycle pain, mid-Leishman's pain due to ovulation. Medication history is a very important thing, and as we know, patient on cortisone will not present to you early with pain because the inflammatory process will not be very clear on them. It will start later on. The patient will present to you with signs, and these patients we shouldn't miss their problems, because sometimes the patient will come to you with very vague pain while he has already ruptured appendix. But because of the inflammatory process is very slow in these patients who are taking, for example, cortisone, those patients, they will not present to you with signs and symptoms like others who are not taking such medications. Family history very important, and also travel history. Let us go and take some examples. This is actually, we explained it in the first slides, that mid epigastric pain will come from these organs, and mid abdomen will come from these organs, lower abdomen will come from these organs. As an example, for example, here, also here, maybe you have appendicitis, or you have taflitis, which is inflammation of the cecum. Here are examples of both the site and the onset and character of the pain. So let us take here one example only, like abrupt excruciating pain, for example, biliary colic, ureteric colic, ruptured aneurysm, etc. So you can just review them by reading them, and in your mind already you have the basic principles how to interpret them. Here also some examples. So the physical examination of the patient should start with the global assessment. So you have to look at the patient. If the patient is stay still on the bed, or the patient is rolling over, and this will indicate the status or the diagnosis of the patient. So for example, patient who is rolling on the bed, most likely he is having colicky pain and he cannot stay still on the bed. Patient with peritonitis cannot move too much, so he will try to stay still, and because any movement can increase his tenderness. Also, you have to look for other signs of general appearance, Is the patient, for example, cachectic, well built? For example, patient who is having a duodenal ulcer for a long time, and now he presented with a perforated duodenal ulcer. Maybe he has well built patient with perforated gastric ulcer. Maybe he will present to you with cachexia and etc. So there are a lot of examples. We cannot mention all of the examples here, but you will go to the related lecture and this is will explain it to you. Vital signs. You have to look for the patient vital signs, which are very important. Maybe those patients will need resuscitation before you start doing for them even history. So vital signs is important. You have to connect the patient to the vital signs from the beginning, and monitoring of his pulse, blood pressure, temperature, and to look for all of this while you are evaluating the patient in the ER. So the patient who is having, for example, hypertension, you have to resuscitate him with fluid, and maybe the patient is severely dehydrated, so you have to give him IV fluids. Patient who is febrile, start him on antibiotic before the complication of fever will come on the patient, whether he's adult or pediatric. And also patient with tachypnea, also maybe he's getting very shallow breathing to prevent overstretching of his abdominal muscles, because there is parietal peritoneal inflammation, and this is common sign of peritonitis. The patient who's tachycardia, for example, as we said, maybe the patient in shock and needs a lot of assessment regarding his tachycardia before you start his formal physical examination for his abdomen. Then you will go directly to his abdomen. After you examine the patient generally, you will look at the abdomen for moving of the abdomen with the respiration. You will look for scars. Maybe this patient is having a previous surgery and presented to you with intestinal obstruction. Then after the inspection, you will go for auscultation, and we start with the auscultation before palpation and percussion, because maybe if you start with the percussion or palpation, this will cause some sort of paralytic ileus of the patient having peritonitis. By your hand, you will increase the pain and will decrease the motility of his intestine. So this is very important to make sure that you don't touch the patient abdomen by your hand before auscultation. So then you will proceed with this, your auscultation to listen to the bowel sounds. After you listen to the bowel sound, you can go for bruit or venous hump as indicated by your history and by your expected by your expected differential diagnosis. You will ask the patient after that to cough to see if there is any pain with coughing, and this is an indication of peritonitis. And so this, if this positive, which we call it Dumfries sign, it is a Dumfries sign. We can write it here so you can keep it in your mind, that maybe it is very important, especially for appendicitis. So it is Dumfries sign. So this is another important sign which we have to look for it. The specific sign, actually better to go for them in the relative lecture for the conscience. For example, acute appendicitis, you will find the causes. You will find the signs which you have to look for per lecture. For example, acute appendicitis, acute cholecystitis, and we will talk about them briefly later on. Then you will go for percussion. You will check for percussion tenderness before you will start with percussion, because it is light and it is very simple on the patient abdomen, and this will not cause for him severe pain like palpation. So better to start with percussion, and then you can go for palpation. You will percuss the patient for percussion tenderness, and this is very important for peritonitis also. And at the same time, if there is no percussion tenderness, you can proceed with your percussion for the ascites, for example, shifting dullness and fluid thrill, if they are positive. After that, you will proceed for palpation, and the palpation you have to look for guarding or rigidity. Guarding, actually, it's voluntary movement, and will make the patient will make it whenever you press on his abdomen. If there is any abnormality like a visceral peritoneal irritation, by your pressure the patient will try to guard himself or guard his organ by stretching his muscle. And this is completely voluntary movement, which you can decrease it by attracting his attention for something else, or you can ask your colleague to attract the patient attention, and you start doing your examination. And then you will look for rigidity. Rigidity, actually, it is involuntary movement, and it is like an arc reflex coming from the spinal cord. The patient cannot control it, and will be a tense muscle over the area of peritoneal irritation area, and this is indication of severe peritonitis. So if it is generalized peritonitis, maybe the patient will present to you with board-like rigidity of the abdomen, and this is common for or a common sign for peritonitis or generalized peritonitis. Then you will go for after this. This is actually the guarding and rigidity. You can detect them by superficial palpation. After guarding or rigidity, then you will go for superficial palpation. The superficial palpation also include local palpation, so you will palpate on the area first very lightly. If there is any tenderness, stop to do any more examination for the patient, because try to avoid any pain that you will cause it for the patient while you are just examining him or examining her. Regarding after you finish your local palpation, you will look for superficial tenderness, and then if you don't find superficial tenderness, you can do rebound tenderness by pressing down a little bit deep, and then you take your hand out. This will cause stretching of the parietal peritoneum, and this will increase the patient pain and tenderness. The patient will express pain, and then you will go for deep tenderness if the organ which is involved with the inflammation is very deep, like what we have just explained in the previous on previous slides regarding some organs are far away from parietal peritoneum, so you cannot detect the tenderness except by deep palpation. Bump tenderness, actually this is a specific sign for peritonitis. Again, you will just shake the bed and you will see if the bump tenderness causing tenderness for the patient by shaking the bed. You will look for masses, and then you will go for special signs also. Of course, if there is any pain or anything, you can avoid to do any palpation, and as we said, start the palpation, deep palpation away from the area of the pain. Special sign, you can go for relative lectures for example, acute appendicitis, acute cholecystitis. Everyone, it has a specific signs of pain. External hernias and male genitalia are very important to check them while we are doing examination of the abdomen, as we know that we have to look for the hernial orifices, especially inguinal area, which is usually covered by the patient's clothes. So you expose the patient very nicely up to mid thigh to look for the inguinal region to roll out any obstructed hernia. And you have to look for male genitalia, especially the scrotum. It is very important because it is part of the abdomen, and you have to examine them and you have to include them in your abdominal examination. Abdominal examination will never be completed except by rectal examination in male and female, and pelvic examination in female. A rectal examination can show you bogginess of the abscess formation inside while you are pressing on the wall of the rectum. You might find some bogginess which indicate formation of abscess underneath, specifically for appendiceal mass, for example, or maybe you will find masses also in the rectum, which can explain perforated bowel. And then you will do pelvic examination in female to rule out any pelvic causes. For example, pelvic inflammatory diseases. You will find that the patient having purulent discharge coming out from her genitalia, and this is indication of severe inflammation. Maybe this is a cause of her abdominal pain, can present it to you like appendicitis. The pelvic examination also is very important in the ruptured ectopic pregnancy. All childbearing female, you should examine their genitalia by doing pelvic examination, and to check by vaginal examination to see if there is any abnormality. Here actually we have some helpful signs for every condition. For example, I will take just an example like peritonitis. As we said, the patient will be motionless, cannot move, absent bowel sound on auscultation, cough and rebound tenderness will be positive, guarding or rigidity will be positive for these patients. For example, if I have paralytic ileus, the patient will have distinction, minimal bowel sound or absent bowel sound, and no localized tenderness, different from the intestinal obstruction because it will have visible peristalsis or hyperperistaltic movement on the auscultation. Maybe late you will find quiet abdomen, diffuse pain without rebound tenderness, hernia or rectal masses in some cases. According to the condition, you will look for helpful signs to get you the diagnosis. These are the most common condition, and these are their helpful signs. You have to look for them and collect your history, physical examination together to give very relevant, to give a relevant diagnosis and appropriate to give a relevant differential diagnosis, and also to rule out any other possibilities of other diagnoses. After you finish your physical examination and you make your list of differential diagnoses, you have to go for investigation. We'll start with the laboratory. You will look for investigation in two ways. Actually, we have two types or two strategies for the investigation, and these strategies actually, for example, first I will do laboratory first to confirm your diagnosis, or to roll out other differential, and at the same time keep in your minds maybe this patient will need OR, so you will do investigation to prepare the patient for OR. So first you will do CBC to check for hemoglobin of the patient, WBCs if it is high, indication of infection, and if WBC is differential, if WBC is left shifted or going with neutrophilia, maybe this is indication of bacteria. If it is the lymphocyte, going with viral infection or parasite on eosinophilia. Hematocrit if the patient bled before he presented to you, urea and creatinine, especially in patient with vomiting, LFTs to roll out any liver failure or liver problems or obstructive jaundice, and you will check for obstructive jaundice actually for you will check for obstructive jaundice by bilirubin and high transaminases if this is affect the liver. I mean the jaundice maybe that will affect the liver and the patient will have high transaminases, and you will differentiate between high bilirubin due to obstructive jaundice and by high bilirubin due to a liver problem by high enzymes, high transaminases of the liver. Alkaline phosphatase also indication of obstructive jaundice. Albumin and total protein are very important for liver failure, amylase and lipase for pancreatitis. Patient who is having, for example, acidosis, This is maybe you will get it by then you will look for ABG of the patient for acidosis, especially patient we will suspect ischemic bowel, for example. They will have high lactic acid in their blood, and this is urine analysis by dipstick to rule out any UTI. And by the way, we can mention here very interesting information that the patient may be having appendicitis and will have positive dipstick for leukocyte because irritation of the ureter by the inflamed appendix or appendiceal abscess around it. So this is will be very clear. Or childbearing females, they should have pregnancy test. Maybe this is just ruptured ectopic pregnancy. And also to see if the patient is pregnant, you will choose the right medication and the medication which is not contraindication during pregnancy. In the radiology examination of the patient, you will do plain chest X-ray, plain X-ray, especially chest X-ray. Why? Because sometimes it may show air under diaphragm, which indicate this is air under the diaphragm, and this is another air under diaphragm. So this is especially in erect. So if the patient is standing, the gas will go up and it will accumulate under the diaphragm. And these are indication either perforated viscous or the patient has done surgery recently within the last 5 days. Abdomen erect and supine to rule out intestinal obstruction. As we see here, we have multiple air fluid level. This is 1, this is 2, this is 3. So this is the erect abdominal X-ray, and you will do supine X-ray to see the cutoff sign. Ultrasound here will show us, here we can see that there is gallstone and some rim of fluid around it. It indicates acute cholecystitis, and also you will see, you will look for the CBD if there is dilated CBD like in this patient. And also maybe it will help you to diagnose appendix in equivocal cases. So the ultrasonographer or the radiologist will tell you that there was probe tenderness over the right iliac fossa, for example, in appendicitis, and you will maybe you will find also distended appendix more than 6 millimeter in diameter and peri-appendiceal fluid and hypervascularity, as we can see here by duplex ultrasound. Ultrasound can help you also to see if there is any free fluid, which indicate that the patient is having a perforated viscous or he is having ascites and he got primary peritonitis, for example. Transvaginal ultrasound and pelvic ultrasound, you will do it in patients who you suspect that there is some gynecological problem or obstetric problem like ruptured ectopic pregnancy, or if the patient having pelvic inflammatory disease, you will find that the patient having free fluid in the pouch of Douglas. Contrast study like gastrografin or barium enema, IV contrast in angiography to see if there is any ischemic bowel. This is actually the gastrografin. As we see here, it will be it will show us the cutoff sign, the dye, it didn't cross the area of the obstruction here, as we see in this patient, in this type of patient. CT scan, actually it has very specific indications, because as we said that one CT scan equals 400 chest X-ray. So you don't use a CT scan except with clear indication in acute abdomen patient like unexplained abdominal pain, equivocal examination, acute on chronic illnesses like acute pancreatitis on chronic pancreatitis. You will see background of calcification on the abdomen, retroperitoneal structure, especially pancreas, and it has specific indication to do for them CT scan, and when, at which day. You will go through it inshallah during you are taking the lecture. Bowel ischemia by the CT angio, it will show you the cutoff sign of the blocked vessels, or maybe it will help you in the diagnosis of appendicitis, especially in pediatric. Sometimes actually you cannot diagnose the patient. So you will directly go to explore and to see what is going on. For example, you'll go by laparoscope, or according to to your experience and according to the patient situation. Maybe you'll start with exploratory laparoscopic exploration, or you'll start with exploratory laparotomy directly. Sometimes you'll need endoscopy to see if there is any gastritis or something like that, by help of our colleagues in gastroenterology. This is a very nice picture of appendicitis, and here we can see the inflammation, and here also there is a rim of a fluid inside. You can see it very clearly, and this is how can help us the laparoscope. It shows the appendix very clearly inflamed. You can take the appendix, so the laparoscope can be diagnostic and also therapeutic. There are some people, actually they are specific people. The elderly people, their differential diagnosis is not like adult people or pediatric. So for example, the tumor with them is more, not like other people or other patients. Past medical history and differential diagnosis will affect. For example, patient with diabetes will have several conditions that will present him with abdominal pain. High mortality and morbidity in this patient will keep us really alert, and we cannot discharge any elderly patient with acute abdominal pain without clear diagnosis, because they have high mortality and morbidity. Unfortunately, sometimes their presentation will not be typical like presentation of other bariatric patients. A challenge in diagnosis because they are over obese. Maybe you will find that the patient having some tenderness, but you cannot detect it by your physical examination because of the obesity. Maybe if the patient is post-surgical sleeve gastrectomy or bypass, the anatomy is not like other people, so you have to make sure that you don't miss anything, and the area of the organs is not like other people. We have to keep this in our mind before we take decision. There are common post-surgical complications with a patient, like a patient who after sleeve maybe will present to you with leak, and the patient will have sort of peritonitis. In the pregnancy, ectopic pregnancy should be ruled out. There are some causes of the abdominal pain in the pregnancy, like stretched around the ligament. During late pregnancy, the patient may present to you with severe abdominal pain, and you will say that most likely this patient having appendicitis, and at the end of the day you will find that this patient doesn't have appendicitis, just as overstretched around ligament. And also the pregnant patient, their appendix is not at the same area of the patient who they are not pregnant, so the appendix will go higher up, and the patient maybe will present to you with right hypochondrial pain rather than right iliac fossa pain. Immunocompromised patient will have low response, and the cortisol effect on their reaction to the injury, or what I mean that injury, that like inflammatory process and appendicitis or cholecystitis, will not be like other patients. Examination findings can be obscured by the presence of the cortisone, or by the immuno impairment, or due to the immunocompromise. In the immunocompromised patient, the examination findings will not be very clear with you sometimes, because their reaction not like the patient who they have normal immunity. So is it surgical? This is the question which you have to ask yourself about it after you finish your clinical, radiological, and laboratory investigations. You have to ask yourself, is this surgical? Actually, if you have sudden, sharp, increasing in severity with time, or persistent pain, this is most likely going with surgical abdomen. If the patient having signs of peritonitis, this is going with surgical abdomen. Here there are a lot of causes that can be non-surgical abdomen. For example, let us take an example like diabetic crisis, diabetic ketoacidosis. Maybe the patient will present to you with acute abdominal pain, acute intermittent porphyria, and also hematological disease like sickle cell crisis. Maybe the patient will present to you with a vaso-occlusive crisis, or maybe the patient actually has having only pneumonia, which referred as a referred pain. It appear on his abdomen, and this is very clear to roll them out. So just you can look for them, but first you have to roll out surgical abdomen and then look for other causes, and this will be very clear for you after your clinical, radiological, and laboratory investigations. There are actually indications to take patients to OR. That means the patient will need urgent intervention like inflammatory guarding or rigidity, especially if spreading, I mean it is diffuse and not localized, increasing or severe localized tenderness, tense or progressive distension, tender abdominal or rectal mass with high fever or hypotension, rectal bleeding with shock or acidosis, and etc. There are a lot of indications for surgery, especially in equifocal abdominal finding that you couldn't find any clue about your diagnosis, but the patient is still unstable, like he has high leukocyte count with high fever and other changes. You have to take such patient for OR. Some radiological finding will indicate OR also, like pneumoperitoneum, like free gas under diaphragm, gross or progressive bowel dissension, free extravasation of contrast material, endoscopic finding if you find that the patient having perforated or uncontrollable bleeding lesion. So once you see your patient and you clinically evaluate the patient and you add your radiological and laboratory investigation, either you will take the patient to the operation, or if it is uncertain, admit the patient. There is no harm of admission, and observe the patient every 2 to 4 hours to look for his pain. Maybe the sign didn't appear yet. You can keep your eyes on this patient till the signs appear, and there are specific indications for admission, that the patient having persistent pain, or the patient having fever, patient having a specific sign that will tell you that the patient having appendicitis or peritonitis, for example. So you will admit the patient and observe him you will observe him while he's inside the hospital every 2 to 4 hours. If it is non-surgical or non-specific abdominal pain, then you can you can consult your colleague from another department to come and to see your patients. Thank you very much. This is the whole lecture, and